Hi everybody, you are listening to the Medea podcast series. Medea Medical Education Academy is a global medical education provider dedicated to designing, delivering and evaluating medical education programs worldwide. Today we will be speaking with Jacqueline Jonklaas, currently a professor in the Endocrinology Division at Georgetown University in Washington D.C, as well as past president of the American Thyroid Association. At the end of this podcast, learners should be able to address treatment expectations when initiating LT4 treatment and understand that maximising quality of life for patients with hypothyroidism is complex. This podcast is part of the continuing medical education programme entitled Hypothyroidism 2026 Importance of Personalised Treatment, targeting endocrinologists and other healthcare professionals involved in the diagnosis and management of thyroid disorders.
Greetings, my name is Dr. Jacqueline Jonklaas. I'm an endocrinologist in Washington, D.C. in the United States, and I treat thyroid diseases in general, but I have a particular interest in thyroid cancer and, pertinent for this discussion today, in the treatment of hypothyroidism. So I'm very pleased to be here.
It seems counterintuitive that patient satisfaction does not mirror their euthyroid state. Do you have any thoughts as to why this may be?
So I think the answer to this is very complex. When individuals with hypothyroidism are treated with levothyroxine, their quality of life certainly does improve, but it may not always return to the anticipated baseline. So if we sort of backtrack to an individual that has an intact hypothalamic pituitary thyroid axis, there's a continuous interplay between the various thyroid hormones that is different in different tissues and cells. So when the native thyroid gland is not functioning and the complexities of the thyroid hormone environment have to be replicated by exogenous thyroid hormone, it's not surprising that it's difficult to mimic the subtleties of endogenous function. And in addition to the peaks and troughs of thyroid hormone levels in the blood when levothyroxine is given, as opposed to the steady and carefully regulated levels with endogenous function, there's also the minute-to-minute regulation of tissue levels, which may possibly be less effective with thyroid hormone replacement. There may also be other components of the thyroid gland whose role we do not appreciate, and it's therefore possible that exogenous thyroid hormone, the T4, does not produce euthyroidism in all the tissues of the body. An additional consideration is what the target TSH is in an individual being treated for hypothyroidism. So we don't really know what this should be, and this is because an individual's personal set point from prior to the onset of their hypothyroidism is not known. Another important issue is the non-specific nature of symptoms of hypothyroidism. So when someone is initially diagnosed with hypothyroidism, not all the symptoms that they have and that led to them being screened for the hypothyroidism may actually be due to hypothyroidism. And many individuals, understandably, may expect all the symptoms that they have to resolve with thyroid hormone. However, if a subset of the symptoms were not actually due to the hypothyroidism, these symptoms would not be expected to resolve with thyroid hormone. So examples of these remaining kind of issues or symptoms, even when an individual is biochemically euthyroid, could include sleep disturbances, weight gain, and difficulty exercising, just for example. So discussing realistic expectations about which symptoms can be expected to resolve with patients, in a frank physician-patient discussion may improve satisfaction. And patient education to increase their general knowledge about hypothyroidism may also be helpful. Along the same lines, other comorbidities may exist concurrently with hypothyroidism, which would remain and potentially cause symptoms even after thyroid hormone is initiated. So studies suggest that these other chronic medical conditions also do contribute to decreased quality of life. In addition, being diagnosed with a chronic condition just in the form of hypothyroidism itself may also have a negative impact on quality of life. Many individuals with hypothyroidism have autoimmune thyroid disease. There are data that suggests that thyroid autoimmunity in of itself may impair quality of life, even if the individual has not yet developed hypothyroidism. And if this theory has merit, it could be that thyroid peroxidase antibodies themselves negatively affect patient well-being, independent of an effect due to thyroid hormone levels. And then with respect to the thyroid hormone levels, these levels, for example, decreased T3 levels, do not seem to be associated with the decreased quality of life. So again, very, very complex.
Has the use of T3 been explored in patients with low quality of life, despite good thyroid function test results?
Yes, indeed. Multiple studies have assessed the impact of combination therapy that involves the addition of T3 to T4 on parameters such as health-related quality of life, as well as other parameters such as memory and cognitive function. Overall, these studies do not indicate improved quality of life with T3 therapy. Admittedly, these studies do have a number of shortcomings, including the variable instruments used to assess quality of life, the non-physiologic T3 regimens, and the short duration of most of the studies. Some post hoc analyses do suggest that a subset of individuals who have worse quality of life at baseline while taking their baseline T4, however, may derive a quality of life benefit from T3 therapy. This does point out another limitation of most studies in that study recruitment generally has not required poor quality of life or patient dissatisfaction as an eligibility criteria for being in a combination therapy study. So it is quite possible that different study results may be obtained in the future if only patients who are unhappy on their levothyroxine therapy were entered into trials of combination therapy. Interestingly, meta-analyses of the 15 or so studies of combination therapy, while they do not support improvement in quality of life with T3, do point to improved patient satisfaction with the combination therapy. And this is very interesting. This does raise the issue of whether our current quality of life instruments or assessments do not necessarily detect all the nuances and aspects of quality of life that are then internally incorporated by the patient into their satisfaction with therapy. So more research is definitely needed in this area.
Can you briefly address the links between hypothyroidism and depression?
So the interrelations between hypothyroidism and depression are multiple. Firstly, an individual with depression may be more likely to be screened for and subsequently diagnosed with hypothyroidism, even if the hypothyroidism is not the etiology of the depression. On the other hand, undiagnosed, untreated, and undertreated hypothyroidism are all associated with depression. So both elevated TSH concentrations and furthermore elevated levels of thyroid peroxidase antibodies are associated with depression. For those who have been diagnosed with hypothyroidism, subclinical or mild hypothyroidism does not seem to be associated with depression. However, autoimmune hypothyroidism and hypothyroidism treated with levothyroxine both do seem to be associated with depression. In a very recent meta-analysis, the association between depression and hypothyroidism was not quite as robust as some of the individual studies had shown previously, but was nevertheless strongest for overt hypothyroidism and in women. Some success has been reported in treating depression with thyroid hormones, particularly when used as what is called augmentation therapy for refractory depression. However, there are clearly risks to be considered when using such an approach, as often such augmentation therapy results in a suppressed TSH. So again, this is an area about which we still need to learn a lot more.
What take-home messages do we have at the end of this podcast?
So I think maybe 3 take-home messages for consideration. So the first would be that a comprehensive discussion with patients at the outset of their therapy would prove helpful to ensure adherence to therapy and also advise patients about what are realistic expectations of their therapy. As a second take-home point, treatment of hypothyroidism should be approached on an individualized basis. The same target TSH and thyroid hormone dose and type of thyroid hormone may be different for everyone. And then a third important point would be that optimizing thyroid hormone therapy needs to take into account the patient's coexisting medical problems, which may affect both the treatment of their hypothyroidism and their satisfaction with therapy. Thank you.
Thank you for listening to this mid-year podcast. For more information about our continuing medical education programs, please visit our website at midyearacademy.com.